Okay, so we're back. We're ready to start that second slide that we want to wrap this whole thing up, this tutorial up. I have lost my voice a little bit, so you're going to have to bear with me. This is definitely the point where I took a break, and this is the next day, and my voice is so hoarse. I hate that. But that's okay. We're going to get this done. And so, where we left off, where we were at the slide where we were now ready to talk about the last circle, right? The BLS before ACLS, and then it says next slide. If you look off to the right of that, you'll see VFib / pulseless VTach. Remember, pulseless VTach could be tricky sometimes because she could be monomorphic VTach or she could be pulseless VTach, right? And then off to the left side, you see VFib, pulseless VTach. Off to the right side of that circle, I want you to write in there PEA / asystole, because I forgot to type it in there. And those are the end of our abnormal heart rhythms, folks. So do you see how by categorizing them, we were able to take what looks like a lot of abnormal heart rhythms and condense them down so it didn't really appear as though there were that many? Right? Let's test your skills a little bit. Let's go back real quick to bradycardia circle. When we were talking about the blocks, remember we were talking about the 2nd degree heart block. And so I want you to take a quick peek at look at your abnormal heart rhythm pages. You have 4 of those, 1 through 20. And I want you to take a quick peek at, I thought I had the exact one I wanted you to choose. Oh, I do. Number 3. Take a quick peek at number 3. So this is a test. All right. Look at number 3. And just to yourself, after watching the tutorial last night and gaining that insight and knowledge, what did you learn? You learned first that 2nd degree heart blocks were typically bradycardias that were missing a what? A QRS complex. And then we decided that we had to decide whether they were 2nd degree heart block Mobitz 1 or 2nd degree heart block Mobitz 2. So what is number 3? Is it Mobitz 1 or is it Mobitz 2? And if you chose, remember, we decide that by looking at the relationship between the P and the QRS complex, the relationship in time between the P and the QRS complex. And if you look at number 3, the relationship between the P and the QRS complex is the same every time they're together. Therefore, it makes it a 2nd degree heart block Mobitz 2. So if you answered Mobitz 2, you were right. You got it. You got it. Okay? Remember, Mobitz 1 was the one where the P to the QRS wave went long, longer, longest, and then you had a drop. Long, longer, longest, drop. And it just keeps repeating that. Okay? So that is not number 3. So if you picked Mobitz 2, you were right. Okay, now moving on. let's go to our very last our abnormal heart rhythms. And those are our lethal heart rhythms, aren't they? They're the ones that do require BLS before ACLS, right? And so this is where I just want to remind you that in BLS, you want to make sure you're compressing to a depth of at least a third of the chest cavity of the person that you're working on, right? And that will happen to be about 1.5 inches for babies, 2 inches for children, the average child, and about 2.5 inches for the average adult. But if you're looking at a 90-year-old Filipino woman who weighs 88 pounds soaking wet, we're not going down 2.5 inches. We're going down a third of her chest cavity. Okay, so make sure in BLS that you're compressing to a depth of at least 1/3 of the chest cavity, so that when you do so, blood's rushing out of the left side of the pump or the heart, and blood, when you recoil all the way back up, blood's rushing in and refilling on the right side of the pump. Right? That's why we want to get down 1/3 the depth. What happens if you're not getting down 1/3 the depth? If you're just sitting there going, well, what'd you have for dinner last night? There's no blood going out the left side and refilling on the right side, that's for sure. Therefore, you get no circulation. And then remember in A&P 101, we talk about the body going into the fight or flight syndrome. And so at that point, that patient has gone into fight or flight, and the circulated blood that we've created allows the body to just automatically know to shunt that blood to the brain and the vital organs primarily. And so that's the way it works. That's why circulating that blood is just so important. The other thing that's so important, as we discussed, was about 100 to 120 times a minute. But it's not the numbers that I want you to remember, because none of us count. I know we don't. I never hear anybody counting in these codes. I love clean codes, but I haven't seen a lot of clean codes. I've just seen a lot of codes. Okay, I'm not going to say what I think of them. I just think they're codes. But how about this? Staying alive, staying alive. Staying alive, staying alive. Or, I'm trying to think of the balls that just bounce back and forth, back and forth, back and forth, that sit on the desk of some people, right? It's kind of like swish, 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 swish. So that's about 100 to 120 times a minute. You want that beat, right? And so that's the beat you're looking for. Okay, and so what I do recommend is to help be a team player and have a clean code. In your mind, you're counting, 1, 2, 3, 4, 27, 28, 29, 30. Cycle 2, that's what I would recommend, is just saying what cycle you're going to. Why? Because we only do 5 sets, and then typically we switch to a next compressor. If the doctor or the nurse practitioner or whomever has not already said, hey, Steve, go ahead and switch with Mary. That happens. Sometimes we switch and we don't have to be told to switch. We just switch. But, doing your 30 compressions and then saying cycle 2, and then 1, 2, 3, 4, 5, 6, 27, 28, 29, 30. Cycle 3, 1, 2, 3, 4, 5, 6, 27, 28, 29, 30. Cycle 4, 1. This is also extremely helpful if you were out in the field and you were someone who called 911 and they asked you to go ahead and start CPR. At that point, you could go ahead and be counting quietly to yourself, but you could at least loudly say, cycle 2, cycle 3, cycle 4, cycle 5, because cycle 5 indicates to that 911 dispatcher that, hey, we know it takes about 2 minutes to do 5 sets of 30 compressions. And so now we know she's been doing compressions for 2 minutes, meaning that our victim has been down for at least 2 minutes. So see how it all really comes together. Count quietly to yourself if you must, but at least let them know what cycle you're on. And that's just a tip. Okay, so we're going to talk about VFib and pulseless VTAC. We know what monomorphic VTAC is, and we've already said that monomorphic VTAC, that's number 17. Number 17. Remember the 2 questions that we're asking, right? The 2 questions we're asking, are they symptomatic and do they have a pulse? So in this case on number 17, she's definitely symptomatic, but she does not have a pulse. That makes her pulseless VTAC. Therefore, we're not cardioverting number 17. We're defibrillating number 17. Okay? And so that's what we're going to talk about now with VFib, with pulseless VTAC, and with polymorphic VTAC. When they're symptomatic and when they're no pulse, we are going to begin CPR. All right? And so that's where you go to your next slide. And if you look over to the left of your slide, you see that I have that algorithm or care plan already mapped out for you. You see at the very beginning, we begin with CPR, right? And we do CPR for how long? 5 sets of 30 compressions, which takes about 2 minutes. Now, your RN that's documenting this is usually the one who lets the doctor know, hey, it's been 2 minutes, doc. And at that point, he says to the RN that's controlling the defibrillator, okay, I want you to go ahead and set the defibrillator for, 180 joules. And so she does so, and she, goes through her charging, and during charging time, we continue compressions, right? And then she says, okay, everyone clear. Everyone indicates that they're clear. And then she says, shocking on 3, 2, 1, shock delivered, resume chest compressions. And so we resume chest compressions. So CPR definitely comes first, then we shock to the amount of joules that the MD gives us. Then we resume shock CPR immediately after shocking. And after that shock, we resume CPR again, right? Remember in the old days when we used to stop and check for a pulse after each shock? We don't do that anymore. Remember, we immediately resume CPR. Okay, I'm going to show you in just a minute why there's one reason why we really don't need to stop and check for a pulse. But what happens after that second shock? And guys, don't get fooled. A lot of people think that American Heart Association only recommends 1 shock, CPR, and then start epi. No, it's 2 shocks, then you start your epi. And so you see that I typed that up for you, 1 milligram of epi, and then underneath that CPR. Now, that CPR is just enough to circulate the epinephrine, okay? So not a full 2 minutes, but 30 to 45 seconds of circulation of the epinephrine, and then we shock again, all right? And then we immediately resume CPR. And that CPR will be for a full 2 minutes. Okay? And then we're going to try some amiodarone. And I put on there that, we can give up to 450 milligrams of amiodarone to a patient, but Not at one time. But we can give 300 milligrams. So we're going to try that first. And so that's what we're going to do. And that's written right there, amiodarone, 300 milligrams. And we're going to then start CPR, but not for 2 minutes, just for 30 to 45 seconds, just enough to circulate that amiodarone, right? Because the half-life of amiodarone is fast, right? And so you go ahead and the nurse that's in charge of giving the meds, whether it be IV or IO, goes ahead and delivers that amiodarone, indicates that she's done so, flushes it, and then we immediately resume chest compressions for about 30 to 45 seconds, just enough to get it circulated, and then we shock again. All right, and then what do? Where are we at? Well, we're going to start epi again. Remember, epi, every 3 to 5 minutes we can give epi. Every 3 to 5 minutes we can give epi. It's important to know. Every 3 to 5 minutes we can give epi. And that's for PEA too, and asystole. Every 3 to 5 minutes we can give epi. All right, so without getting off track, we have shocked after we gave the amiodarone. We began our CPR for 2 minutes, and we went ahead and delivered 1 milligram of epinephrine again. All right, and so we circulate that for about 30, 45 seconds, and then we go ahead and shock on the doctor's orders, right? We go ahead and deliver another shock. And then we resume CPR. And then finally, we're going to try the last portion of that amiodarone that we have, which is 150 milligrams. We're going to go ahead and give that, circulate it for about 30 to 45 seconds, and then shock again. So then what do you think you do? Let's go all the way back up to the top. And let's say it together. CPR shock, CPR shock, CPR epi, CPR shock, CPR AMI, CPR shock, CPR epi, CPR shock, CPR AMI, CPR shock. There's a pattern there. And it's such an easy algorithm to remember, or care plan, I like to call it. So there is your plan of care for your VFib, pulseless VTAC, and polymorphic VTAC patients who have become symptomatic and unresponsive, not breathing. BLS has been started, and that's how we are going to care for that patient. Now, there's a CPR team that's usually in place. And I wrote that down there for you. And next to CPR, I want you to write the number 2, because there are typically 2 CPR people, right? And then you see I wrote rotator RRT. Just next to RRT, put 2, because there's typically 2 RRTs in there. We typically need an extra RRT in there. All right, then you've got your RN, who's on IV or IO. What's IO? You need to know that for the American Heart Association ACLS test. It's interosseous. Do you know where you can place them? Real quick, I can tell you the sternum, but why would we put it there? We're doing CPR. The humeral head, well, they were in an MVA and it was crushed, so it's a contraindication. Can't do it. The tibial head, the tibia, or the shin, as some people call it. Yeah, but again, they were in a motor vehicle accident. It was pretty bad, and it's crushed also. So we can't go there either. Well, Michelle, I'm out of ideas. I don't know. Where else can you go? Where else can you go? Well, I'm going to sit down here because I want to show you where else you can go. Okay? So I'm going to take my phone and I'm going to show you a medial malleolus. The medial malleolus is what I'm pointing to right now. That's that little bone that we hit on the side of the bed all the time that hurts so bad. That's your medial malleolus, okay? And so did you know that an IO can go there as well? So if they ask you on the test, here are the sites that we have available for IO, which one would you choose? And none of them work except they happen to have medial malleolus on there. Choose that one, okay? Because that's the one they're thinking you won't remember. Okay, so then you have an RN that's on IV or IO. You have an RN that's on documentation. You have an RN that's on defibrillation. And then you usually have your MD or PA, nurse practitioner. And typically with them in teaching hospitals, you have residents. And then sometimes you even have a pharmacist come in, okay? Sometimes you even have a chaplain already there and present. So a lot of hospitals have CPR teams, and they just show up for any code. So I think that's pretty cool, very organized. All right, so there's what a CPR team looks like. My question to you is, what should that CPR team be talking about while they're running what you see on the left side of that page? That code. Not what they had for dinner last night, not what they watched on TV. What they should be talking about, you will see on the right side of this page, is called the H's and the T's. An American Heart is brilliant in coming up with the H's and the T's. Okay? So let's go over them quickly because there's 5 of each. And I want to point something out that's going to make a light bulb go off for you. Any of these H's and T's can actually be the underlying cause of any of our abnormal heart rhythms that we went over last night, right? They can be the cause of any of these abnormal heart rhythms that you have on the slide. And so I just want you to keep that in the back of your mind. Consider any of the H's and T's when you identify an abnormal heart rhythm. Can it be coming from, number 1, hypoxia? Could it be coming from, can the abnormal heart rhythm be coming from hypoxia? Well, I don't know. I mean, we're in a code situation, and doc, I'm giving them 100% FiO2. I can't get many more than that. And someone says, yeah, but they were in a bad motor vehicle accident and lost a lot of blood. What carries oxygen? Red blood cells. So what might we give them to fix the problem besides just oxygen if they were hypoxic? Packed red blood cells, right? So there you go. There's 2 answers for that one. The next H is hypovolemia. Hypovolemia is a big reason why a lot of people go into having abnormal heart rhythms, right? Hypovolemia. And we know that we need to bring their fluid levels up, right? Whatever fluid that might be, we need to bring that up. If they've lost a lot of blood, we've got to replace it. If, we can replace it with fluids, we're going to replace it with fluids. So then what's the other one? Hydrogen ions. There's another H, which we all know as acidosis, right? And when someone is acidic, when their blood is acidic, that means that they are lower than 7.35 pH, They're acidic. What can we do to offset that so that abnormal heart rhythm might go away? Bicarb. Bicarb. Write that down. Bicarb. Okay? All right. Then your next H is hyper and hypokalemia. Hypo and hyperkalemia. Potassium is extremely important to the heart. And so if we have hyperkalemia, we know what we need to do. We need to get them some potassium on board. If they're hypokalemic, well, I can't make them poop while I'm running a code. I can't give them an albuterol neb while I'm running the code. I guess I could. But you nurses, old timers out there, you know what you're going to give. Insulin. 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 Okay? How about hypothermia? Well, here in Florida, I hear a lot of students say, oh, Michelle, we're not going to see that very often in Florida. Yeah, you will. Post-op. Post-op is probably when you're going to see hypothermia. Okay, so keep that in mind. How are we going to fix it when we identify it? Well, bear hugger. You all know this. And then warm those IV fluids. Best way to warm somebody quickly is from the inside out. Then go to your T's, guys. Tension pneumothorax. What do we got to do to fix that while we're running that code or while they have their symptomatic abnormal heart rhythm? What can we do to fix that abnormal heart rhythm? We've identified the problem is a tension pneumothorax. We're going to give them a chest tube. That's where your resident's just dying to get in there. Then you've got cardiac tamponade. Cardiac tamponade, right, is oftentimes a reason why we have a lethal heart rhythm, right? So what is cardiac tamponade? A lot of people don't know. Cardiac tamponade, if I were to draw a heart, the heart sits. I'm going to grab my blue and I'm going to switch it around so I didn't draw. So the heart sits, kind of has a sac around it, right? I am not an artist. And inside is called the pericardium. And sometimes it can fill up with blood or fluids of different kinds, pus. And so the heart is trying to beat and beat and beat. And it's beating now. The more fluid that gets into the pericardium, the harder it is for that heart to beat. It gets harder and harder and harder. So what we want to do is go ahead and tap that pericardium using a needle and a 60 cc syringe, and we want to go ahead and try to pull that fluid out of that pericardium so the heart can relax and go, oh, thank goodness I can beat again. You know, I was struggling against all that pressure, but now I can beat again. Okay? And that's what cardiac tamponade is, and it's a huge reason why someone goes into abnormal heart rhythm, especially our lethal ones, right? And oftentimes we can't pick it up quick enough, but keep that in your mind. That's why American Heart wrote that on there under the H's and T's. Cardiac tamponade is huge. How about toxins? It's one of my favorites because anything that makes the body unhappy, I have a word called unhomeostatic. If they are unhomeostatic in their body, it's a toxin to their body. Say, for example, what's the first thing that comes to your mind? Drugs. Okay, drugs. Intentional or not. How about sepsis? How about, oh, I took him for Thai food. I didn't know he was allergic to peanuts. That's a toxin. So lots of things can be toxins. And so we want to address that so that we can reverse that abnormal heart rhythm as well. All right. And so then the last two are kind of blood clots or thrombosis, right? We've got pulmonary and cardiac thrombosis. Okay. And so basically with those, we know that we need to break them up. Cardiac thrombosis, typically you might have an MI, you might have with a pulmonary thrombosis to go ahead and start some fibrinolytic therapy, right? So be aware that those are your two last T's. Those are oftentimes reasons why someone can have an abnormal heart rhythm, especially the lethal abnormal heart rhythms where they become unresponsive and stop breathing. It's been let go so long and they threw a clot and it's pulmonary. So those are your H's and your T's. Okay, now, last but not least, I wrote in the middle of the page in black bold letters something that you see that's called capnography. And I want to speak briefly on this because you're going to see it on the test. You're going to see something about capnography on the test. American Heart is bringing it up more and more and more. And so, a spontaneously beating heart like yours and mine right now has a PCO2, write this down, right underneath spontaneous heart, I have 35 to 45. Beside that, I want you to write PCO2. Because that 35 to 45 is indicating the PCO2 of the blood, okay? For a spontaneously beating heart. That's what we would expect it to be. All right, so there are three things that are just fabulous about capnography. First of all, a lot of people aren't aware of what it is. Well, you might have seen someone come out of the OR and they have a funny looking nasal cannula on, right? Little thing hanging down here. That's capnography. Tube coming off of it, running up to the telemetry. They plug it into telemetry and all of a sudden you have PCO2 reading. And so you're able to monitor that patient's CO2 while they're waking up. So post-op, I've seen those almost a lot, most of the time. But in a code situation, we can place a little plastic piece on the end of an ET tube, and it also has some tubing that goes up to the monitor, and we plug that in, and that instantly gives us another reading called PCO2, and that is our capnography reading, okay? And so on here, I have that if there's three things that are valuable about capnography, and these are the three things. Number one, you can write number one next to manually circulated heart. The capnography should read greater than 10 in somewhere between 10 and 15, okay? So for manually circulated heart, The capnography should read greater than 10 to 15. So what do I mean? I mean, Steve's doing quality CPR, right? He's going down 1/3 the depth of the chest gauge at bum, 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 staying alive, bum, 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 bum. So he's doing quality CPR. And we look up on the screen, and the documenter documents that the capnography is, in fact, 16. So we know that Steve's doing quality CPR. But the opposite could happen. The documenter could look up on the screen and see that the CO2 reading is 8. What does that tell you? Well, that's number one, why capnography can be so important. 8 means Steve's not doing quality CPR, is he? He's not getting deep enough. He's not recoiling. He's going too fast. He's going too slow. But somewhere, some way, he is not doing quality CPR. And so capnography can tell us if we have quality CPR going on simply by looking at the numbers on the screen. It's valuable information. Sorry, I just went down the wrong pipe. Speaking of which, is number 2. I say capnography shows placement. And actually, that should have been number 1. But put a number 2 beside that one. So we've put the little piece on the end of the ET tube. We've hooked the little tubing up to the monitor. We now have a capnography reading of a PCO2. We're manually resuscitating him, so we expect that it should be somewhere above 10 to 15, somewhere up in that range. And so I intubate the patient because the doctor has ordered me to do so. And then I add the capnography piece and hook it up, and the reading shows 0. But we're all expecting to see 10 to 15 or higher because we know Steve's doing quality CPR. They all look at me and go, "You're in the wrong tube. You're not in the trachea. You're in the esophagus." Well, how do you know that? Because the PCO2 is reading 0, and there isn't any CO2 in the esophagus. So, number 2, capnography is valuable in showing placement quickly. Okay? And then number 3, capnography is extremely valuable in showing a return of spontaneous circulation. Do you remember that I had shared with you earlier that I'm going to show you that we really don't ever need to stop, and check for a pulse if we have, I didn't finish the sentence, but if we had capnography on the end of our ET tube and it's hooked up to the monitor. This is assuming that the doctors ordered the intubation and we've gone ahead and put the capnography on the end of the ET tube, hooked it up to the monitor, and we have a PCO2 reading, meaning that we have capnography in place, and Steve's doing quality CPR, so we've got a nice up to 10 to 15, 16, 17. He's actually up there at 18. So I know he's doing quality CPR. And then all of a sudden the documenter says to the doctor, "Doc, the PCO2 has just jumped to 38. What does that mean? What would you think? I would think the doctor's going to say, "Stop CPR. Check for a pulse." Because 38 falls in the normal range of what our PCO2 should be anyway. Remember? the very beginning, we said 35 to 45 is normal for a spontaneously beating heart. So if that documenter looks up and sees